Thank you so much for the opportunity of actually presenting in addition to moderating today on the global response to cervix cancer. Global statistics from the International Agency for Research on Cancer indicate that in 2012, approximately 16% of the 6.6 million cancer cases and 14% of the 3.5 million cancer-related deaths were among women. Cervix cancer accounted for 527,000 new cases and 239,000 deaths. While cervix cancer is the fourth leading cause of cancer-related death across the globe, it is the #1 cause of cancer-related death in Africa. Data from the World Health Organization indicates that 45% of cervix cancer-related deaths occurred in China and India, secondary to their large populations. Cancer-related deaths calculated per 100,000 women confirm that countries throughout Africa were locations where cervix cancer was the deadliest. Messaging around the vaccine itself is something that we have to clearly strategize. There's been a lot of misinformation that's been put out about the vaccine, which has made it challenging for countries to embrace it. The HPV vaccine affects 9 in 10 women in their lifetime, almost 14 million per year in the U.S. alone. HPV is associated with the development of molecular alterations that lead to cervix cancer, and there's been some people in the community that challenge what is the association with HPV with cancer. Vaccines are typically minimally effective in those already exposed to HPV, and therefore it's a preventative instead of a therapeutic. Vaccines do not promote promiscuous behavior, and this has been borne out in many evidence-based studies. HPV does not cause infertility, and HPV vaccines are long-lasting. There's been a number of agencies that provide oversight to manage the adverse effects associated with the HPV vaccine, to include the Centers for Disease Control, the FDA, and the Vaccine Adverse Effects Reporting System. This reporting system is a national database that's maintained by the CDC. It does have limitations, but ultimately we have tracked almost 70 million cases now to date, looking at associations between the vaccine and adverse effects. Severe adverse effects in case-by-case analysis have not been shown to be causal in relation to the HPV vaccine. So the analysis of death, Guillain-Barré, which is a neurological disorder, autoimmune diseases, etc., have not been found to be causal. It's very important for messaging around the vaccine, if public discontent or problems arise, to be handled very diplomatically. In 2009, the vaccine was licensed in Japan. The government subsidized delivery of the vaccine in 2010, and in 2013 added it to its list of routine vaccinations that were given to school-aged children. Following implementation of the vaccine, several cases of chronic pelvic pain were noted, and these were very much sensationalized by the news media. 2 months later, the Ministry of Health suspended its recommendation for HPV vaccinations. The government subsequently did a due diligence assessment of these cases and found that there was no causal relation between the vaccine and the adverse events. Unfortunately, the public opinion had already been compromised. Public mistrust was very difficult to redefine, and coverage has dropped from 70 to 5% with not a improvement in the vaccine now. Important communication from the CDC following this really provided a number of important recommendations to consider for healthcare policy. Number one, you need to be the first to provide the information, be accurate with the information, be credible. Getting your subject matter experts and other physician leaders, researchers involved in whatever political opinion is put out. There needs to be an expression of empathy, there needs to be an actionable result from that, and there needs to be respect. Additional issues with messaging, in addition to getting the correct information out to the public, is that women deserve the right for equal health care. We need to move towards removing stigma, as was mentioned previously, because in some healthcare environments, this can lead to problems within the marital relationship in terms of even complaining about the signs and symptoms. Women who have problems have reservations about seeking care because ultimately they assume they have the diagnosis if they end up being seen by a provider. And in many areas of the world, the word cancer itself is taboo. We really need to involve not only the physicians, researchers, but advocates and educators. We need to work with the government officials and even the religious leaders, because in certain areas of the Middle East, we can't really talk about these types of issues without being sensitive to the religious parameters within which we need to deliver the information. Lessons learned have been reported by the teams in Peru, Uganda, and Vietnam with their national programs, and I think we need to definitely listen to what their reports have provided so that we're not making the same kinds of mistakes or facing the same challenges in an independent siloed dynamic. School-based and commune-based healthcare strategies are ideal. Doing this in the school system, timing it with school year activities is critically important. Having the actual teachers themselves involved in the administration of the vaccine and at least educating both the students and their parents about this is really key. Community outreach and preemptive education is also essential, and messaging we've already spoke to. We talked about having to transcend the religious, cultural, and political boundaries. It's an important component for this delivery of information. We have enormous opportunities to disseminate information given we are in the information age. 7 billion people on the planet, almost 3 billion people use the internet. Almost 3.5 billion people have a cell phone. We need to be more active about putting our information out, which has been done by many countries now, through texts, through email, through social media like Facebook, etc. We had done a social media blitz last year as part of Globe-athon, and in the course of the year we had about 120,000 people on Facebook. The list of countries on the right just is a kind of a list of those countries that were most active in social media. So many of these are developed countries, some of them are not, and I think, again, we just need to emphasize that opportunity. Screening that both Dr. Parham and Dr. Shastri had spoken about is critically important. The WHO has put together a guide to essential practice for healthcare providers. The map that's depicted shows that in the dark blue countries, this is where we have actual national programs. This includes developed and developing countries. In the light blue, this is where we have pilot programs. Gavi, or the Global Alliance for Vaccine Introduction, created in 2000 with a grant from the Gates Foundation, has been quintessential in being able to provide discounted vaccines to those countries that need it most. There's typically two different programs of partnership. There's the national introduction and then the demonstration project. Overall, countries have to demonstrate their capacity for being able to take the vaccine that's been given and being able to implement in an effective fashion, also using non-Gavi resources to make that possible. The countries that have been approved for national introduction include Rwanda, Uganda, Uzbekistan, and 21 other countries are currently in demonstration projects. By 2020, it's estimated that over 30 million girls in over 40 countries will be vaccinated against HPV. Our global progress in HPV vaccination is highlighted here with the dark blue countries demonstrating national programs and the piloted programs in light blue countries. We need to ultimately look towards petitions, which many of the advocacy groups here in this room have been very much a part of in drawing global attention to cervix cancer. And the Globe-athon to End Women's Cancer, as well as My Sister's Health Watch, is really focused on disseminating that information. What's our call to action? Basically, we need to have a collaboration of advocacy groups working together in a very, very spirited and aggressive way. We need to use social media engagement to disseminate information. Our educational outreach doesn't need to focus on one particular attribute. It's risk reduction, early detection and screening, prevention, specialty treatment for those that need care who have those symptoms. We need to have cervix cancer registries. National Cancer Center has been a big advocate for this, as well as other organized cancer organizations around the world. We've had guides for providers made by the World Health Organization. There's a guide for patients that's been recently launched by the Pan American Health Organization. We really need a guide for policymakers to help guard against problems that result in adverse public opinion based on inadequate information, as exemplified by the problems we've experienced in Japan. We need an idea to cast a shadow on what our vision will be. I think that this conference that we have today really signifies symbolically how globally, by working together, we can synergize. Working in independent silos, we are going to continue to have the status quo. So it's time, and thank you so much to Ambassador Antoine and other leadership at the UN to enable us to do this. Thank you.